Hi, everyone, and welcome to Critical Path Institute's Rare Orphan and Pediatric Disease Programs webinar series. My name is Dominique Cruz, and I'm the Senior Project Manager for the Rare Disease Cures Accelerator Data and Analytics Platform, or RDCA-DAP for short. It's my pleasure to welcome everyone to today's webinar, Addressing the Lack of Standardized Laboratory Reference Ranges in Neonatal Trials, Pilot GUI Launch. Before we begin, I'd like to go over a few housekeeping items. If you have any questions throughout the presentation for our speaker or the panelists, please put them in the Q&A chat box. The chat function is disabled for everyone just so we can make sure we don't miss any questions that pop up, and all participant lines are muted just so that we can reduce background noise. We are recording this presentation and it will be available on our YouTube channel post-webinar. And with that, I'd like to introduce Dr. Kanwaljit Singh, Executive Director of Inc. and Director of Pediatric Programs, who will introduce his co-presenters and kick off the webinar.
Thank you so much, Tom. Hi, everybody. Really good to see you today. And thank you so much for joining our webinar focused on our lab values reference ranges project and pilot launching the graphical user interface that we will be demoing today. As an introduction, I'm Kanwaljit Singh, Director of Pediatric Programs at Critical Path Institute. I run our International Neonatal Consortium. And this is one of the projects that we've been working on for the past several years now. For this specific webinar today, I have two of my colleagues from QuantMed program, Quantitative Medicine program, Nicholas Hanshid, who's the senior quantitative medicine scientist with a background in applied mathematics, artificial intelligence, medical imaging, and biological modeling. He's been working with us at CPAT for almost 4 years now and has supported a variety of projects across different disease areas using a very wide range of modeling frameworks. Then we also have Rachel Zhu, who is a QuantMat developer who comes with a statistics background. At CPATH, she's been responsible for developing the graphical user interfaces for all different consortia and the programs that we do. And she has been one of the people responsible for actually creating the graphical user interface. With that being said, let's move on to the next slide. I just wanted to, I think there are some people who are on the call who are already familiar with the International Neonatal Consortium, but for others, I just wanted to introduce INC, which is basically just like any other public-private partnership at Critical Path Institute. This has been in existence for past 10 years with our mission to it's a neutral, pre-competitive consortium of stakeholders from industry, academic researchers, nurses, families, patient advocacy members, and regulators with a mission to accelerate drug development in the neonatal population and for the neonatal population. So we operate as a pre-competitive collaboration with the dual mission to improve the predictability of neonatal drug development and address the measurement of assessment of clinical outcomes in NICU by undergoing data sharing exercises and basically doing our work to advance regulatory science to de-risk the conduct of clinical trials in neonatal populations. And our focus has been on all of those disease areas that are listed in here that are relevant to premature babies that are admitted in the neonatal intensive care unit. Next slide. So coming to this actual lab values project, why we wanted to do this initiative in the first place was because people who work in NICU in neonatal drug development setting, they probably would know that unlike older children, or definitely unlike adults, the neonatal lab value reference ranges for most of the commonly used labs in NICU are actually not standardized at all. Each individual hospital has their or institute has their own reference ranges. In many cases, they are basically kind of ported over from older children, and people just have their own ways of actually creating those reference ranges, which leads to inconsistent interpretation across studies and across hospitals. So we wanted to actually change that. The way we did it was to develop a regulatory grade data driven foundation where we obtained a very large amount of data from different electronic health records, many of them in the US, some of them outside of the US too. We used that to create basically, standardized, very robust modeling to create basically what we think are reasonably generalizable reference ranges for many neonatal labs. But we didn't want to stop there. We also wanted to make our project easily available and accessible. So we created this interactive graphical user interface, or a standalone software or an app that enables users to explore these lab values and their ranges dynamically across different neonatal age strata, by gestational age and by postnatal age. I think this, to my knowledge, is one of the very first in the world cross-institutional neonatal lab value reference ranges platforms using real-world data. It enables harmonized interpretation of safety and efficacy results in neonatal trials. The reason being that if you do not by reliably know what is normal in when it comes to neonatal labs, you certainly wouldn't know what abnormal is, right? And if you don't know if you are not reasonably sure what abnormal is, you're not going to be able to reliably use that measure as a safety endpoint in your clinical trial. So basically, it establishes a regulatory ready framework for use in drug development programs and for future quantitative and modeling tools. Next slide. Okay, so here I'm going to give the screen to my colleague Nick Henshield, who has been one of our main people who did this entire lab value references project. He's going to go over some of the specific technical details on the specific labs, how the analysis was done, how the graphical user interface was created, and so on and so forth. So Nick, please go ahead.
Sure. Just audio check. Everyone can hear me? Good.
Yes, we can hear.
Yeah. All right. Great. So, and I just looking through the participants in the chat, I know that I've met a lot of you, and a lot of you have participated in previous calls regarding this project. So, a lot of this won't come as news to a lot, but for those of you who haven't interacted with this project so much, I'm going to go through a bit of the background, where the data comes from, our approach to modeling the data, some of the potential challenges that we faced as far as extracting these reference ranges from real world data. And then just taking a look at what the future potentially looks like with this project. So I think that one thing I'll say right off the bat is that this project was really opening the door to a lot of possibilities for what can be done with EHRs and real world data in general in this population. So there's techniques that we can develop and things that we can do that we've just barely started to scratch the surface. So to give a brief overview of what the data looks like, so the INC database it cuts across a wide range of different study types and different specific populations and from different locations. Internationally, from both the US and internationally. The data that we used for this lab values project, this initial modeling pass, was from 3 major NICUs in the US. And we pulled electronic health records from those, and we did a process of mapping those data to the OMOP format. And the OMOP format is a standardized way to represent not just electronic health records, but really any data type can be put into this format. And so after some data curation steps, we end up with about 16,000 subjects in our database and over 1.5 million measurements. Now, there's heterogeneity, of course, in the number of measurements that we have given a particular analyte and a particular age range, both gestational and postnatal age range. And so the plot that you see on the right is showing the distribution of counts, record counts for each lab. So each little rectangle box you can see is corresponding to a particular lab. So like you have glucose, hemoglobin, BUN, hematocrit. And then the size of the dots and the rows and the columns correspond to the rows are gestational age and the columns are postnatal age bins, and then the size of the dot corresponds to the record count for that subject. So for some, like glucose was the largest number, and if you have like 38 to 40 weeks gestation, 0 to 7 days, we have over 40,000 records for that particular bin. But then as we get into some of the more sampled data or analytes than we have. And it was hard to get the scaling to make sense with this, but sometimes only a few hundred records. And so that's one of the challenges that we have collecting these labs on our own and saying we need this many samples from this population. We basically have to deal with what we have in the database. And so in part that's one of the big caveats I think is that um, you, you know those of you that come from a more traditional lab setting and are familiar with the way that reference ranges are, there's an understanding of the way things are done traditionally, especially in an adult population. And I think that there's a degree to which understanding reference ranges in this population needs to be adapted to, the caveats with the data and the fact that there's modeling involved, and a few additional things like that. So I just wanted to point those things out early on. The 14 analytes that we've looked at initially are listed on this slide. This list was established from basically consensus, getting input from INC members. So if there's anything that you don't see on this list that you really wish that you would have, reference range for, then it's almost certain that we have the data in our INC database. And then we just need to, in our next round of modeling and development, we can take a look at any of those. So I'm sure that there are things that would be helpful in trial designs or even in clinical care that, oh, it sounds like my audio is not working well. I'll turn my camera off and see if that helps. Is that helping? Does that sound better?
Yeah. Thanks, Nick.
Okay, great. Yeah, sorry, I'm on ad hoc internet at the moment, so great. Was there anything major that totally cut out?
No, I think you got it all.
Okay, great. Yeah, so I think what I was saying is that if there are any labs that you don't see in this list that you think are a priority for your program, whatever that might be, whether it's clinical or drug development, then just let us know, reach out to INC, and we can include it in the next round of modeling, because the database includes many, many more labs than what's listed here. The other thing to point out on this slide before we move on is that we did decide to bin across gestational age. And this was mostly due to data counts and due to the model that we decided to pick. It was easier to separate the data, to pool the data across gestational age bins, just in order to reach the data counts that we needed to run the model that we had. This is the approach that we had to take. Initially, we only had 3 gestational age bins, and then we got feedback from FDA and from Inc. members that we really wanted more gestational age bins, so we were able to create one more. And this is something I can get into later on, but there's a different modeling approach that we can take where we can treat gestational age more as a continuous variable instead of as a binned grouped variable. And then the other thing is, and we'll talk about this more on the next slide, is we don't exclude any subjects based on any particular indications other than if they had a discharge status from the NICU of deceased. And that's the only way that we filtered. Yeah, someone is actually asking this question right away. Oh, that's from John. Yeah, so I think the goal, again, is with reference ranges is trying to understand what the profile of healthy looks like in this population, and not necessarily trying to understand what the profile looks like for abnormal or unhealthy. And so I think that this is part of one of the Pandora's box doors that we've opened with this project, is because we have so much more additional information in the AHR, we can start to change the definition of what a reference range is and look at this more as a predictive precision medicine type model, instead of looking at this is what a normal range is, and this is anyone outside of this normal range is considered abnormal. So that's the reason that we excluded deceased individuals, was to try to yes, in a sense, bias the model towards normality or trying to extract what we think is normality out of this population, which is obviously challenging. So anyway, it's a great question. Can we move on to the next slide? Okay, so I alluded to this already, and it's this idea that because we're working with real world data and not explicit study data where we can include or exclude subjects based on a predefined normality criteria, we're working with real world data. And so it's a mixture of what we would call non-pathological and pathological cases. And the way that the modeling deals with that is taking essentially a data-driven approach where we assume that there are some subjects in the population that are non-pathological, and we assume that there are some subjects that are pathological, and we assume that we can extract that information purely from the lab values themselves. And that's, I think, a point that, I'd be happy to discuss offline if that's even possible, or if we really need to dig into other information that we have in the EHRs to think about that question. But this is the approach that was taken by a group that has developed what the model that we ultimately used for this, which is called the refine-R technique. And they make this assumption that there are some subjects that are pathological and some subjects that are non-pathological. And we treat this as a mixture distribution. And so the histogram plot and the distribution fit that you see, there's a very obvious central peak. And then there is basically two different dynamics that are happening. There is a low abnormal peak, and then there's like a heavy tail that's happening. So the group of subjects that are to the left of this central green peak, those are considered abnormal, statistically speaking, and then the heavy tail to the right is considered abnormal. And this is what the model does: is it tries to find the central peak, and then it fits it's not a normal distribution. This looks normal, but it allows for skew and kurtosis using what's called a Box-Cox transform. So it's a pretty broad statistical model that fits, but it just fits to the central peak. And that's to account for this idea that it's a mixture distribution of pathological and non-pathological. The other challenge that we ran into is the fact that, and this should be well understood to the pediatrics world, but in adult populations, you don't normally have age dependence, but obviously in this population, you have age dependence and both gestational and postnatal age. And so that's another thing that we had to account for, is that there's variability across time and across gestational age. And so again, we treated gestational age as a bin variable. We pooled across that, and then treated the postnatal age as a continuous variable, and used a technique called GAM-LSS that I'll talk a little bit about on the next slide, in order to model the continuous variability across postnatal age. And I think, that the four plots on the right are just demonstrating this variability across gestational and postnatal age, using box plots. So, share what 3 EMR. That's probably a question for you, Kamaljeet. I don't know if we can share the specific EHRs, but there are 3 NICUs from the United States.
So what I can say is they're all 3 EHRs from the US, and all 3 of them very large tertiary reference level children's hospitals. That is basically because of patient privacy reasons. We're unable to, at this point, unable to share those specific EHRs where those data come from, but they are coming from 3 large children's hospitals in the US. I think this is to do with patient privacy reasons, is one of the reasons. But after we get permission from those hospitals, we'll be happy to get you those actually specific names.
Yeah, so that's probably a good idea, is to just wait until the end for Q&A. So, okay, I think we can move on to the next slide. One thing that does bring up, though, and this is something we could talk about later, is whether we have consistency across the different hospitals, and that's something that is we're still working on. But as far as I've been able to tell, just by doing leaving one hospital out as a test set, I've seen consistent results when you train the models on 2 out of the 3 and then test on the remaining third. So far, it's been consistent, at least among these 3 hospitals, and there's not a lot of variability across the different sites. So, okay, this slide describes the modeling pipeline and how we deal with the age variability. And again, this is following the work from a group that comes out of Roche that developed this technique. So they initially developed the refine-R technique to deal with just real-world data, lab values that don't have time variability, and then they had a follow-up paper where they developed a technique to deal with variability really across any covariate, but they, use the example of pediatric ranges where they want to understand how the reference ranges change over time. And so the way that the pipeline basically works is you bin using a sliding window. So you pool across a given, and this is for a fixed gestational age bin, just thinking about postnatal age. So you use a sliding window. And so the 2 plots that are bottom left, the first one is 0 to 5 days, and the second one is 2 to 7 days. So that's what I mean by a sliding window, where it's a 5-day window that is overlapping. And so you fit the model. Again, this is the technique that assumes a pathological and non-pathological, so it fits to a central peak. And that's what the green distributions are, is fitting to that, what the model thinks is the non-pathological subjects. And then once it's fit that model in those sliding windows, then it uses that to assign a probability, so a number between 0 and 1, that each data point is non-pathological. And that's what the color coding on the right corresponds to. So anything that is close to green is going to be close to a probability of 1 of being non-pathological, whereas the red dots correspond to points that were assigned a probability close to 0 of being non-pathological. In other words, those points are likely to be pathological. And so this is a thing that I think is a bit of a subtlety with this model, is that looking at these plots, like if you only look at the centile curves, that's probably what people are most familiar with. But I think it's also important to understand, because this is real world data and because we're having to assign a probability that a given data point is pathological or non-pathological, it's also important to show that. And when we get into the actual GUI, I think that we'll talk a little bit about whether those scatter plots will eventually be available in the GUI. They're currently not available for data sharing reasons, similar to what Kamaljeet was referring to. And the statistical method, if anyone is interested, we can talk more about this offline. And get really into the weeds with this, but it's a method that's called GAM-LSS, and that stands for Generalized Additive Models for Location, Scale, and Shape, which is a way to, it's like a regression model, but instead of there just being a mean that you're modeling the dependence of a mean and also other shape parameters, location, scale, and shape parameters. And you can regress on those as well. So it's an interesting statistical technique, and that's what allows us to get these centile curves. So what's shown, the actual curves in this plot, are centile curves that are extracted after the GAM-LSS model is fit. I think we can go to the next slide. Okay, so I referred to this a little bit, how we've basically just opened the door and we have a lot more to do. The current process that we're undergoing is really trying to go through validation and sanity checks. So one thing that you may point or thought about is, because we have EHRs, we have access to condition and observation. Those are tables that are present in our EHRs. So we can look at diagnosis codes, ICD codes. We can look at observations, and we can try to match up. Does the model predict abnormality, and does that correspond to the any observations or diagnoses that are actually made? And going through that is a little bit of a slow process. I'm trying to cook up some different machine learning techniques that could be used to do those checks, but it's been a little bit slow to go through that. And then there's a host of different modeling improvements, even if we only look at the problem as it is now, which is trying to understand like the dynamics of different labs compared to just postnatal age and gestational age. There's improvements that we can make to the models. But there's also more advanced modeling that we can do that's more akin to the idea of a digital twin model or a personalized prediction model that I've been working on. And I think that that's where the real power would be here is if you are trying to use this type of tool for clinical decision making, I think it would be more helpful if you had a personalized prediction model. And theoretically, with a large enough data set of electronic health records, that's something that you can do. So we're working on that. That's hopefully coming in the future, but it's going to take some time to build that. And this is basically what's in the last bullet is the AI machine learning approaches for patient-specific prediction. So the goal would be given labs up to some time and covariates that you have and some interventions that you have made, can you predict the future labs and outcomes for time greater than now? So this is just in a diagrammatic sense what we would be wanting to do with this personalized prediction model. So that I think is a super interesting future project. And then I guess the other thing that's not written here, but I've already said out loud, is if there are additional labs, additional covariates that the community is interested in, we almost certainly have those in the database, and then we just need to prioritize them in the next version of the model and the app that we build. I think we can probably go to the next slide. Okay, so I'm going to go through just a quick overview of the GUI, and then I'm actually going to pull up a live demo. And if the demo gods are with us, I'll be able to actually show all of these behaviors. So the GUI is really pretty simple. You have some options on the left to select the analyte, select the gestational age bin. And then you have tabs on the right that give different plots and different readouts for the model. And then below is giving for a given postnatal age, it gives a readout of what the reference range is for that specific postnatal age. And so I think probably what I'll do is I'll actually maybe jump to the live demo now, because there's a couple things that are different in this figure than what is in the live demo. So if I can steal the screen share, I will hopefully, if everything goes well, give a live demo. All right. Is everyone able to see? You should see a login screen for is that seen?
Yes.
Great. So this is what you'll see when you get and this link is live, by the way, if anyone wants to go to this right away. You won't have the username and password, but you'll notice that there is a register here button that'll allow you to fill out a Microsoft Office form, and we're just collecting just basic information, and we're not assigning individual logins. There's a universal login. So this isn't so much because we're trying to protect like data security, and I'll explain that in a moment. This is just to collect information on who's using the app. So, and then there's just a single login. And okay. So then there's a little pop-up, and it just gives a caveat that says this, the statistical methods are experimental and to take it with a grain of salt. And that you can leave comments and questions or concerns under give feedback. Okay. And so one thing that was shown in the slide that is not currently, and so what plot of the real data, and then we realized that there was some data sharing law that had just been passed like a month ago or 2 months ago, and we had to pull the scatter plot. So what we're doing is we're generating synthetic data that we're going to be able to share, and that's how we're going to get around that for now. And then we'll talk about this a little bit more later when we talk about the long-term deployment of this app, because we have another plan for long-term deployment that would get around that rule. So you can select, like I said, you can select your analyte, and you can select your gestational bin. And then you click submit. And then if you want to select a specific postnatal age, like let's say 14. Yeah.
You're
What's up?
breaking. Sorry, I think you were breaking up.
Oh, I thought I heard. Okay. Let me sign off and back on. I'm sorry. My internet is obviously not stable, but let me link to my phone really quick. Sorry, hang on.
Hi guys, apologies. I think there was some sort of an internet issue. Nick is going to be back in just 1 minute while we get started with the discussion all over again. So do you want to move back to the GUI slide number 10? Yeah, so while Nick comes back, I just wanted to provide you with an overview of what this is actually look like. So in the postnatal age, you can actually enter the days as far as 30 days. Beyond 30, the data becomes unreliable. But this is pretty decent in terms of providing for a given postnatal age, for a given gestational age bin. On the bottom side of it, it provides you with a color-coded graph of sorts, which tells you that the 50th, the blue line, that is vertical line, will show you the 50th expected 50th percentile for that specific postnatal age within a gestational age bin. And then it'll also the top half is the percentiles: 2.5th, 10th percentile, 25th percentile, 50th, 75th, 90th, and 97.5th. And the bottom numbers are the actual expected values for that specific lab value. And then this basically will provide you an idea and overview of what the specific level reference ranges look like. Nick, I think you're back. If you wanna
Yep.
share your screen, I was just explaining what this graph actually looks like.
Yep. Thank you. Yeah, sorry about that. I'm using kind of ad hoc internet today. We're in the process of moving, and so someone is in the house cleaning, and it's just everything is a little bit chaotic. So, okay, are we back?
Yes.
Great. Okay, so I think what Kanwaljit was describing is this graph down here. So if you select a specific postnatal age in days, then you'll get a readout that tells you the centiles 2.5, 10, 25, 50, 75, 90, and 97.5. That's for a specific day. The curves, again, are the centile curves versus age, and that is shown here, and I think this should include this. Those are apparently the labels are a little bit cut off. I wonder if my browser might be zoomed in, but at any rate, these are again the centile curves. One option that I'm working on implementing is to change this. Instead of being centile curves, we can change this to mean plus or minus standard deviations. That's another option that we've heard some interest expressed in showing that, and that's something that we can work on. So this is basically the basic usability is selecting your analyte, selecting gestational age bin, and then you get a readout for what the curves are versus postnatal age. And then again, if you put in a specific postnatal age, then you can see a readout for that specific age. And then the other tabs that you see are you can look at the individual binned refine our model fits. And what this is telling you is for binning across postnatal age from, in this case, this is from postnatal age is a half day, so 12 hours up to 12 days, 12 and a half days. If you bin across all that data, what is the reference range for that? And again, you should be able to, just using the marker tool, determine what these different values are. So this is saying that it's between 23 and 180 for this particular postnatal age bin for this analyte. And then you can select. So these are all the sliding window bins that were used to build the model. So this gives a little bit of a like under the hood look into what's happening with the modeling by looking at the different sliding window bins. And then there's additional information that you can see, and this is not specific to the analyte. This is just specific to, or this is just general information about the data and general information about the modeling and some important caveats. And then an opportunity to give feedback using a survey. So that's the basic functionality of the app. I don't know if there's anything else that we need to go through. Kamaljit, you can tell me if you think that there's anything that that I missed. Otherwise, I think we could probably go back to the slides.
I think we covered pretty much everything, unless you want to just go over a couple more labs and show how they look like, but that's really
sure. Yeah, it's it's the kind of thing that just like warrants being explored on your own. I think, yeah, the other thing I wanted to point out is in some of those screenshots, there's an option to turn a scatter plot on and off. That scatter plot functionality will return to this app, but we have to generate synthetic data in order to do that. And that, again, goes back to this data sharing law that was just implemented a couple months ago that we have to now satisfy, where like no patient data of any kind can be shared without serious restrictions on access. Okay, so I think we can go back to the slides, and I believe Noelle is going to reshare.
Yeah, we'll start again at 14.
Okay. So I think the next thing that we're going to talk about a little bit, and I believe I'm going to pass to Rachel to talk a little bit about the design and architecture of the GUI itself, and then to talk a little bit about the longer term deployment plans with this. And then we'll leave a little bit of time at the end for questions. So
yeah,
Rachel?
We already have several questions in the chat, but I think we'll wait until the end to get to those.
Okay, sounds great. Thanks, Nick. I can take over from here. So like he said, I'll be talking a bit about the design architecture of the GUI, as well as our deployment plan following this current version. So the components of the GUI could basically be split into the front end and the back end. In the front end, we have a variety of UI components. So in the page where you get to select the labs from the drop-down menus, and here it says tick boxes, but that is, as I'm going to elaborate later, it's not yet available. But these are values that will get passed to extract the correct plots. So due to plotting time being quite a not a trivial amount of time, we sort of are not making them on the fly. We made them prior and then stored them to extract them. They're still fully interactive. Secondly, the other UI component is, or the input parameter is the numeric integer value you put, which is the PNA in days, which is used to calculate and then generate the second plot that looks like a spectrum. And then additionally, there are just a bunch of various pop-up info boxes that are also part of the front end. In the back end, what's happening is we are extracting the data, extracting the plots, sort of making slight modification to them before presenting them. And as well as on the second tab, there was the refine our plots. And finally, what's happening on the back end is the actual calculation and the generation of the quote unquote box plot, which is not a real box plot, but Next slide, please. So as you guys have seen in the demo just a second ago, once you obtain the link, which I'm sure will be distributed either today or at a later time, but once you get your hands on the link, this screenshot on the right-hand side is what you will see. And do go ahead and use the register button which will take you to the intake form. And all the information we're collecting is your name, your affiliation, just to get an idea of who is interested in using the GUI. And we also would need your email to send that link to your inbox. And one other thing that I do want to emphasize on again, but Nick's already mentioned this. Inside of the GUI, there's a fourth tab where we attached another survey link. So we would certainly appreciate your feedback if you have any upon using the GUI. And next slide, please. So currently the tool is hosted on shinyapps.io, but because of certain compliance issues with the data, like it was mentioned a second ago, we are not currently able to make the scatter layer visible for this version. That is not an option. However, at a later time, we will be deploying this on Posit Connect, which is another platform that allows for these data content GUIs in a secure fashion. And for that version, we will be able to provide full functionality. In other words, there will be a tick box that allows you to show or hide the scatter dots if you would like. That option would be available. And then next slide, please. So here are some future actions that we're trying to implement for the future versions of the GUI. One of our main action items right now is to create synthetic data and add that scatter dot to the GUI, to the visualization, again, to be compliant with the ruling with these personally identifiable data. If we were to obtain more data from other real world data, we would be integrating them to part of the modeling and update the results. There are some improvements we're trying to make to the UI components, essentially to beautify things and make them a bit more visually pleasing. And then finally, again, we are hoping to incorporate any user feedback that you might have, whether it's regarding the modeling components or the actual tool, how easy it is to use it, how user-friendly it is. We welcome any feedback that you might have. So those are all the technical parts that I have about the GUI. If you have any questions, please feel free to drop them in the Q&A, and I'm happy to answer them. And I will turn it back to
Apology. Thanks,
Yeah.
Rachel.
yes.
Thank you,
Thank
Rachel. We do have a bunch of questions actually that I would like to cover. One of them is from Mary Short asking, it might be a little early in the project, but what major objections do you anticipate in industrial regulatory acceptance of the data generated by this tool, and how might those objections be mitigated? Nick, do you care answering that? I guess, one of them is probably comes down to generalizability of the data, but do you want to do that? Oh, before we actually even go there, one additional panelist, person that we have on the panel discussion today is Dr. Jagdeep Podishetty, who has been one of our collaborators on this initiative, and he's the Senior Director of Predictive Analytics in our quantitative medicine program. And he has been leading the development of quantitative solutions like disease progression models, survival models, simulation tools, and AI models to advance the field of drug development. So with that being said, we're back to answering the questions that people had in the chat. Let's take up the first question. I don't know if anybody wants to take up this first one, either JD or Nick, uh, to understand what sort of hurdles or challenges do we expect in terms of industry and regulatory uptake for this tool.
Yeah, I'd say generalizability, but in this case, like the word I would use would be more specificity. Anytime you take any information that you glean from real world data is not always going to be specific to the population that you're studying. So if you wanted to use this information in a study on a particular population, and that's, again, a topic that we could get into in the future, and where machine learning is really powerful, and these methods that are based on like the idea of a digital twin or synthetic population can be powerful, is if you have those specific criteria, we could potentially build those in to create like a fine-tuned reference range plot that is for a specific population. That's something that we could look into in the future. So I would say that's the likely objection that we might see is someone says, well, I don't care about all neonates. I only care about the specific subpopulation.
And I also
Yeah.
believe the other thing also would be the fact that there are no normals when it comes to premature babies, right? Everything is abnormal. There's not gonna be a 22-week-old normal baby, right? So that could be another one of those, but it's just understanding that it's the reality. Reality is such that we have certain uncertainties in this, in this entire process, and those will remain. You can potentially mitigate them by adding more data to your model, but going into this with a wide open eyes that this is it is just a reflection of how this field is. But I think JD, you were about to say something.
Yeah, just wanted to make a few comments. So the tool, just a clarification in terms of what the tool does. The tool does not generate data. It's more of, understanding the distribution of different labs. And then as Nick was hinting at, there's a way to model individual or a group of individuals in the data to understand how they progress, which can help, inform trials. So
another question was that do we have enough data, at least in this current model, to say this data are generalizable? How do we even decide or determine whether our lab ranges are quote unquote generalizable? Anybody want to talk about this? Because I don't know, there's a cutoff below which we say it's not generalizable and above which we say it is generalizable.
So it's always difficult with real world data because okay, so as a general idea, the way that we're approaching this is because we have multi-site data, we can do like we can leave a site out and build the model on remaining sites and then test on the site that's left out. We would call that external validation. And I've done some of that, and like I mentioned, the results are so far seem promising for at least these three. Now, these are 3 US-based NICUs. There's going to be a reasonable amount of consistency there. Where we start to get into trouble is if we want to generalize to other systems that use different standards or different ways of measuring different analytes, then we start to have to build in some sort of normalization or harmonization. And then I think there's this, I think that you could go more into once you've harmonized or normalized across these different sources of variability. If you understand the source of variability, then you can normalize for it, and then it could be more generalizable. So and this is, I think, part of the nature of looking at, pooled data, multi-site data is you build model on the data that you have, and you can try to answer the question of generalizability within that circle. And then if you want to bring a new data set in, you just have to be careful to understand if that new site has done things in the same way, and if not, what types of normalizations do you have to do to bring the data from that new site in. So I hope that makes sense. So we're studying generalizability. So far, we think it's reasonable, but there's always going to be caveats and things that you have to do and be careful about.
Yeah, one comment I would make is the amount of data we were able to, collect from different sites. I don't think anyone else was able to do that. That by itself, helps us make it more generalizable. Just piggybacking on Nick's comment on, sites, effect of different sites. We could also think about limiting the use, if need be, of this tool in the sites that the model was trained on. And then we are still getting more data, so you sort of can expand it to broader, make it more generalizable that way, if you want to be very conservative, I would say.
And we are actually adding new data sets to the model. We're in progress to add like international sites like from Japan to the model currently as we speak, which is going to be updated very, very quickly. But I hope it answers the generalizability question. Then the other question was, will this database include clinical data such as APGAR scores, treatments such as pressors? I believe the answer to this is yes. But Nick, do you want to speak to that?
So the database has that information. The question is whether we have incorporated it into the lab values modeling, and the answer to that is currently no. But that's where, again, we've just opened the door. And now that we see what is potentially possible, we could look at something like APGAR score as a covariate and see if there's any correlations or associations between something like an APGAR score and any of these lab values. I don't know. I'm not a neonatologist. I don't even know if that question makes sense. But just as a covariate and outcome question, you can start to answer some of these correlations and associations. So we have the data. We can just look into it.
Yeah, I think our future plan would include accommodating for adjusting for in the analysis some of these covariates, which is going to be a topic of discussion in terms of what are the most important covariates that actually we believe will influence those lab value reference ranges. So we will basically work on incorporating that in the V2 or maybe V3, I guess, depending upon how quickly we can get to that. The other question was, will we analyze data from diseased individuals? It could be quite revealing. Actually, Bob, we already answered this question. So the answer is maybe. I think this is going to be like another one of those things where we will probably try to see if including diseased individuals changes the results significantly. If it does change the results significantly, then we'll have that discussion in terms of how to best adjust for that. One of the rationales was that we were not sure. There's no, we wanted to make it as normal as is possible, and diseased individuals were like very much abnormal, quote unquote, simply because of the outcome. Was one of the reasons why we in the initial iteration only wanted to focus on those individuals who survived basically. Then the other question was, is it possible that the analytic instrumentation and protocols at different sites will vary enough to influence their data? I think that is more about like site level variability, and my understanding is GAM-LSS methodology accounts for that, but I'm going to leave it to Nick to answer this question, whether our methodology adjusts for and accounts for analytic instrumentation and different protocols at different sites.
So this is definitely a challenge with real world data and EHRs is we don't always have that information. That information is not always provided to us by the sites because and so essentially we have to treat it as a potential source of variability, a potential random effect in the data. And so to answer that question, that's where going back to this idea of generalizability, if you know that you suspect that there's something that might be a site-specific variable that's influencing your quantity that you're modeling, you would see that come out in the generalizability like validation study, where if you leave this site out, train on the other two, say, or other n-1, and then try to generalize to this site, if you're not getting good scores, like if you're not seeing that matchup, then that's potentially a site-specific variable that you then need to track down. Now, in the future, what would be ideal is to try and encourage sites to record that information really specifically. And this actually, some of the people that I think are on this call, we participated in putting out a position paper on best practices for publishing lab value information and normal ranges. And part of that is recording the analyzer and the specifics about how you collected the specimen or the sample and how you stored the sample. But that information just typically isn't available in EHRs. So when you're modeling, you have to just treat it as a source of variability that is either quantifiable or unquantifiable. So it's a really good question, and the answer is we're not always sure what that looks like.
Thanks. So we just have time for probably one last question because we're approaching time rapidly. When I asked about, there was a question from Maria. When I asked about the EHR systems, she wanted to find out whether the centers are part of networks that share clinical data, such as one Vermont Oxford Network or Neonatal Research Network, and can we link them both? I believe yes. I'm not 100% certain if one and these type of networks actually have that type of clinical data available. We'll have to take a look at that. I mean, we do have actually, in our EHR database, we currently already have data sets in the list pending something like 15 or 20 EHRs that we already have. And before we even start to get into VON or NRN's data, we probably would like to get that current data into the current model, the ones that we already have, before we start expanding this. And as Nick was saying, the data sets that we currently have, if we include all of them, our results are all going to be pretty decently generalizable anyways. But on the other hand, this entire project is always going to be work in progress. I don't think there's going to be ever a phase where we say, yeah, this data is good enough. I don't even know where that cut point of what is good enough is even there, right? So that is basically what it is. But we'll keep on working on this. I think this is a good start. Thank you, Marian. Deb, thank you so very much for your feedback, and we will keep on providing regular updates as things continue, definitely. So I think we're good now. Okay, so this is the next webinar. Don, do you want to talk about this one before we close?
Thanks, Kamalji. Yeah, thanks everyone for attending today. We do want to just have the save the date out for our next webinar on December 11th, the last one of 2025. From Vision to Reality, 6 years of RDC ADAPT, driving drug development solutions and innovations in data sharing. The registration will be in your inboxes soon, but we'll also follow up with the webinar recording of this webinar. And I hope everyone has a great rest of their day.
Thank you. And we will be circulating the link to the tool to everybody who listened in today because it's already live and open access. So thank you. So thank you.
Thank you, everyone.
Yes. Thank you. Have a good rest of your day, and really nice catching up with you.